able to learn more about gamma knife today. With this introduction, I request Dr. Sajeev Thomas to give his presentation.
Thank you, sir. Thank you so much for your kind words. I thank God Almighty for this opportunity, and I welcome all you to the physics, technology, and clinical challenges in gamma knife radiosurgery. I would like to disclose some of the product pictures in this webinar are, the downloaded from the net, and I have manufacturers and products mentioned in this presentation. So is it moving, sir, or it is static?
Yeah. No. Now I'm in the first slide, radiosurgery.
It's
outline.
Not moving. Okay.
It's
so
an
I think
outline.
there is some kind of, yeah. Okay. So we will be discussing about the history, gamma knife models, radiation dose calibration, and accuracy of gamma knife, and common quality assurance methods, stereotactic imaging accuracy, and an introduction to the clinical applications. So radiosurgery has an official definition, a modified official definition in 2007 by the American Association of Neurological Surgeons. But it was defined by Borje Larsen, who was a co-inventor of gamma knife, that has a technology with proper immobilization devices and targeting devices with a full definition many years back. So I would recommend all the physicists to go through the beautiful paper. This is published by the AAPM as an anniversary paper, which is detailing the contribution of medical physicists in setting up gamma knife in around the world. So let's start from here. Let's start with the history of gamma knife. The history of stereotactic frame started in the 90s, in the beginning of 19th century, by the invention of the first stereotactic frame for animal experiments. And in 1947, Ernest and Henry developed the first human stereotactic frame in Philadelphia. In 1949, Lars Leitzel in Sweden developed the first stereotactic frame based on the arc quadrant system, which has only positive values. And there are other stereotactic frames which are developed by Talleyrand, Edwin Todd, and Trent Wins in the United States of America. And there are frameless radiosurgery, which is introduced in 1980s. And there are stereotactic localization methods using gold seeds, which are introduced using the CT voxel coordinates in the middle of 90s. And image guidance systems using kilovoltage and megavoltage beams contributed a rapid development in this area. So what are the stereotactic radiosurgery options? Although the term gamma knife is often used for Electa's gamma knife, we need to understand that there are other gamma knife radiosurgery systems from other vendors. Some of the systems in use are OUR gamma knife, that's from China, and Chinese super gamma knife from American radiosurgery, and MASCP radiosurgery, and many more. And other options to gamma knife are proton-based radiosurgery and linear accelerator-based radiosurgery. So I'm not going into the other details. However, we need to understand there are other systems which are using gamma beams for radiosurgery, but they contribute a very small fraction of the market. I mean, very small fraction of the users who are using this technique for radiosurgery. So discussing about the Leitzel gamma knife models, I would like to divide them into two. the models with fixed radiation sources, and the models with the moving radiation source models. So from 1968 to 2004, these models were in the use by most of the hospitals who are practicing radiosurgery. So they were having a fixed source assembly with 201 sources. And the gamma knife systems, the gamma knife perfection and the gamma knife icon has got 192 sources. So that is the key difference from the fixed radiation source-based gamma knife systems to the moving source-based gamma knife systems. That's the key difference. So let us see some more the information about the gamma knife systems. So the fixed source lake shell gamma knife models, we could see here from the prototype models to the gamma knife 4C, they were either using manual fixation devices for fixing the patient to them, connecting the patients with the frame to the machine, or they were using a robotic arm. So the robotic arm was available for the 4C models, and until that time, all the models were using a mechanical fixation device by name Trania. So all these units were having 4 collimators, 4 mm, 8 mm, 14 mm, and 18 mm. So these were the 4 collimator sizes which were used by the fixed source lake shell gamma knife models. So if you look into the cross section of such gamma knife models, we could see here very well. There is these sources are fixed, and this is the area which is the lead shielded area for the shielding of the gamma beams. And there are so 2 semi-cylindrical drums that is for opening and closing the doors of the radiation unit. And this is the patient positioning area where the patient will be positioned with the frame, and with the frame the patient go into the treatment delivery unit, and inside the treatment delivery unit this will go and exactly coincide, exactly connect with the primary. We can see here this is the primary area, the primary beam that will exactly go and connect with this primary beam and thus deliver radiation beams to the isocenter. This was the technology used in B, C and 4C. In 4C units, they were having an automatic positioning system, that is a robotic arm for delivering the treatment. Instead of going inside the room and removing the patient, there was a robotic arm. So this is how the collimators of collimation system of the fixed source geometry gamma knife models looks. So we could see this is the source assembly, and there is a primary collimator with a source body, and there is a final collimator which is the collimator which is used here, and into multiple 201 apertures of multiple sizes. They were having different plex of with different beam diameters. They were used for positioning the sources. So this is the positioning system. This is the gamma knife positioning system which is used for positioning the head in different X, Y, and Z axes. So that limits the application of this equipment to some of the specific locations in the brain. Suppose if there is a tumor or a target which is in the extreme locations in the brain, which were not easy to reach using this system. So that was one of the disadvantage of using automatic positioning system in the earlier versions of the gamma knife. So we should know how the typical gamma knife treatment workflow. So here, always the patient is fixed with the lake shell frame, and once the frame is fixed on the patient, then there will be that will establish a coordinate system, lake shell coordinate system with all positive values, where its center is 100, 100, and 100, x value 100, y value 100, and z value 100. And here we could see that this is the origin, 0, 0, 0 is the origin of the coordinate system. With this indicator box, for the MRI, because if the patient undergoes MRI imaging as the primary imaging modality, this patient undergoes imaging using this MR indicator box. If it is a CT imaging, this indicator box is this CT imaging box is fixed to this frame, and with that the patient undergoes images, and this images being used for delineating the target. This is being used for delineating the X, Y, and Z coordinates in the brain. So then it established a stereotactic coordinate system in the frame where we could direct the beams utilizing the light cell coordinate values. That is the technology used by those systems. Now, if you look into the modern gamma knife options, they have three options. The first option is the Lexell frame-based SRS. The other one is the first one I have written here is the Conbeam CT based, which is used in the gamma knife icon. And the second one is a relocatable frame with a mouth bite, which is used in gamma knife perfection, that is known as extent. And the third one is Lexell based, the Lexell frame based method, that is the one which was used for all the previous versions of gamma knife. So in all these methods, the first step involved is stereotactic localization. For the stereotactic localization, either a fixed frame or a relocatable frame being used, and after that, after the imaging, the plan generated in the Lexell gamma plan, including the CTMR registration for the fractionated radiosurgery. If there is no fractionated or a single fraction radiosurgery, there will be no frame. There will be no CTMR co-registration needed. It will be directly using the MR images. That is how the treatment happens. Now we look into the new trends in gamma knife treatment. We could see that this is the information I received from the Lexell Gamma Knife Society for the year 2018. It shows for single session treatments, majority of the cases, the frame is used, the frame-based radiosurgery techniques are used, and for the multi-session treatments are using mask. So there is a change in the trend in gamma knife systems from frame-based radiosurgery to frameless radiosurgery, especially for multi-session treatments. Now let's see how it looks like and how the perfection or the icon looks like. Here we could see that if you look into the technology and physics, we could see that there is no gross difference from the perfection system and the Electas icon except this component, which is the stereotactic CBCT system. So in the stereotactic TBC system and the high definition motion management systems are the additions to the Lexell Gamma Knife Perfection and replaced with a new name icon. That is the key difference between the Gamma Knife Perfection and icon. Both units are having 192 non-coplanar simultaneous beams, and that ensures a steep dose to the healthy tissues, and it has less moving parts. And the name of the patient device is the patient positioning device is known as patient positioning system. So this is something which we are going to learn today about more detail. If you look into the detail, the cross section of the gamma knife unit, we could see that this is the patient positioning system, and there are shielding doors. And inside this radiation unit, this whole area is covered by lead shielding. Here, this part is covered, this collimator is designed using tungsten. And where all the radiation sources are distributed like a head ring in 8 sectors. Each sector has got 24 sources. So we can see here there are 5 rings for each sector. For each ring, there are 3 combinations. There are 3 different beam combinations. What I say, the collimator combinations. That combination is for different collimators, 4 mm, 8 mm, and 16 mm. So this is how it looks like. but for different sizes of the collimators, this combination is going to be different as what I have seen here. So this is how it differs. The radiation source assembly in gamma knife perfection differed from the other previous gamma knife versions in as displayed in this image. We could see here this gives a lot of space, and here the space is very low. So in addition to that, you can see here this has each ring has got 3 combinations. So each time you need to have a different combination for each beam. So in one ring, we will have the first ring will have 48 sources, the 48 source combinations. The second one will have 32, third one will have 40, and the fourth one will have 32, and the fifth one will have again 40. So this is going to be the source arrangement in gamma knife perfection and gamma knife icon. So the approach for this equipment is much different from the approach for other versions of gamma knife when we look from the physicist point of view. So how do we do the calibration? So most of the centers are using the IAEA TRS 398 or TG21 sources. There are two phantoms which are currently used for doing the calibration of the gamma knife unit. One is the ABS plastic phantom, and the second one is solid water phantom. So there are a number of studies which talks about the assessment of the plastic phantoms and for the calibration for the lake shell gamma knife units. So you could see here, this is a publication from the Pittsburgh group. They have studied different phantoms for different gamma knife units around the globe. It's an international study they have conducted, verifying number of centers and the clinics. So also there is another study from Dr. Petnagar from the same group. He also mentioned about the adapter that is used for the ABS phantom when we are using it for the calibration. So there are a few physics issues which need to be addressed before we make the calibration. So before the existence of this TRS 483, there were no corrections available for the calibration, or the standard reference conditions were not available. But now, after the introduction of TRS 483, there are clear information and the reference standards for each unit. Here the key difference is, in the previous versions of gamma knife, they were using 1.8 centimeter field, that is a 18 millimeter collimator as the reference field. But for gamma knife perfection or icon, the reference field sizes are 16 mm, 1.6 centimeter field sizes. That is a key difference. And another good thing with the TRS 483 is it has given correction factors for the different chambers which are used for calibrations. So those, and also they have given the calibration, the quality correction factor, as well as the water to plastic conversion factor in addition to this. So these correction factors were not available before the introduction of TRS 483. So that is a key difference. So in the gamma knife output calibration, either we can do using an ABS phantom or solid water phantom. But when we use a solid water phantom, we cannot ignore there is a geometrical issue we are facing when we are using this for the calibration. However, we need to also understand the positioning of the ion chamber inside the gamma knife systems also contribute some variations and some, I won't say uncertainties, it is adding uncertainties to the chain of procedure, which is not there with the solid water phantom. So we have number of applications regarding the assessment of variation and assessment of the differences with the gamma knife calibration. So what is the calibration challenge we have? This is my own experience with the gamma knife systems. In the gamma knife systems, when we use especially the ABS phantom, it is possible to position the ABS phantom in multiple positions. Like you can keep it which is exactly perpendicular to the field, or you can have a right entry, left entry, or from the top. This all contributes differences in the error. If you look into the previous publication, you know what we have seen here for the calibration, some of the centers are using in this position, but Electra protocol recommends in this direction. But when we use this one to avoid some of the beams, what happens is, if we look into the profile, if we look into the profile, gamma knife profile, we could see that the X direction, the X plane has got more penumbra compared to the Z direction. That is the reason why we could see this much of variation when we try to make the calibration from the different angles. So this is something which is a challenging task for many of the medical physicists, because in some of the previous models given, there are many centers who are using the calibration. If you look into the picture, if you look into the calibration publications or from many of the radiosurgery groups, this is something which needs more corrections in the coming years. This is what I think from my experience in calibrating this equipment. So talking about the relative output factor measurements, we can see that, as I have mentioned to you, for each ring, each collimator has got 3 different beam geometries. So when we try to estimate the virtual SID, the source to isocenter distance, there will be many more values which we cannot estimate in an ordinary clinical setup. Even Electra use a Monte Carlo code to fit those values to make the calibrations. So these values, the relative output factor values, which are given by the Electra, are measured using the gaphromic filling EBT or EBT2. So these are all the values currently used by most of the centers. So apart from that, this is a measurement from the Pittsburgh group. They used for the using different films, and they also estimated using the Monte Carlo. These are all their published values. Apart from this calibration, we also need to understand that because of the movement of the sources from one position to another position, there are some transit dose issues which are also managed in the gamma plan in the latest versions. So I am not going to discuss into those details. However, there is one more study which is comparing the perfection systems with previous versions of gamma knife. So in that, they concluded the dosimetric characteristics of the gamma knife perfection systems for 4 mm and 8 mm collimators are comparable to the dosimetrical properties of the previous versions, especially the Lakeshell Gamma Knife 4C unit. But the third collimator, which is a 16 mm collimator, cannot be compared here because in both units, in the 4C model has got an 18 millimeter collimator, which is the reference, and here in the case of Perfection and Icon, they got a 16 mm, which is the reference collimator for that units. So what about the radiation safety? So these are all the radiation levels surrounding to the gamma knife Perfection in different locations. We could see that in the back side, we could see the side surfaces, doors, front, and many positions are estimated, and it is also recorded and reported from many places. So these are all the manufacturer's values. As per the regulations, NCRP, ICRP or IEC regulations, these values which are estimated are much lower compared to the values which are mentioned in NCRP, ICRP or IEC protocols. So if there are some centers which has got a door between the control console and the radiation unit, in some of the countries' regulations, it permits that there is a door, there is a glass window, not door, sorry, there is a glass window between the control console of the gamma knife unit and the radiation unit because of the lower scattering and lower leakage from the radiation unit. This is very much possible. So discussing about this gamma knife Perfection penumbra, this is the key difference with the cobalt-60 sources and the electron sources when we are using in a LINAC. So we could see here this penumbra values are much lower for the same collimator opening in case of when we are using the same distance in case of a 4 mm. So this is the key difference we have between this. So if we look into the beam profiles, we could see here the z-axis profile has got lower penumbra in all the three dimensions, x, y, and z. We could make out for all the collimators, we could see that there is lower penumbra. Here, this is for the X profile. We could see that this is higher, the penumbra is higher. So there is also significant difference between a single beam and multiple beams because of the cross firing of the beams. So there is significant difference. But the point to be stressed here is in the z-axis, it has got a better, penumbra. It's a lower penumbra compared to the X profile. So this is the single and multiple beams comparison values. Here we could see that single and multiple for the 16 mm collimator, which is the reference, has got a difference of 2.78 mm. At the same time, the difference for the 4 mm is only 0.82. So this is how these systems are calibrated at the time of installations. And there is a special film holder which is provided by Electa. And we take the values, we take the exposures for X, Y, and XZ planes to determine the radiological focal point from these two films. And that is a special device where we could prick the film using a very small needle, and it is possible to this procedure is done for the 4 mm collimator, which is the smallest collimator, that is to assess the radiological focus point. So after assessing the radiological focus point, this is also compared with the profiles in the Lakeshell gamma plan. So we could see that this is how it is compared with the Lakeshell gamma plan. Then there is one more test device. This is known as the master. This is known as the installation diode. This is used by the Electa engineer to calibrate the radiation profiles for the system in the machine with respect to the diode, which will be utilized on a daily basis in the gamma knife perfection or gamma knife icon. So this is the diode which is used by the gamma knife physicists every day to calibrate the gamma knife system. So this is something like a morning, that's QA, which is what we morning checkout that we do in Linux. So this is something similar to a QA morning. Example here, you could see that there should be a diode test tool. There will be system emergency alarm, radiation monitors, gamma angle variations, docking positions, and many more. Usually these are all the typical QA lists for a physicist to check before the treatment of utilizing this equipment for radiosurgery. In some cases, we also use collision checks. In collision checks, what's happening is here the clearance test tool, because in some of the clinical cases, clinical indications with extreme locations, collision checks at the treatment unit. This is also used. So yeah, this is Lakeshell gamma plan treatment planning system. The previous versions of the gamma plan were using an algorithm by name QLab. So convolution and the new systems and the convolution-based algorithms, the new gamma knife versions are using either the TMR10 or convolution algorithms. So this units also have got this treatment units got an option to perform online adaptive SRS. So there are many publications that I would like to quote two of the newest one from in the physics in Physics in Medicine and Biology, which is published very recently in the February, in 2 months ago. So that compared, that they showed there is 98% agreement between the 1 mm and 1% for the gamma values. And they also compared the TMR10 values with the convolution, the newly introduced convolution-based algorithm. And it was noticed that they have noticed a variation of 7%. But in the case of a comparison which is published from the Prague group, they have observed more deviation from the convolution algorithm, between the convolution algorithm and the TMR10 algorithm, which is used in the gamma plan. However, I am not going to discuss much about this system because then they have launched a new treatment planning software by name Gamma Plan Lightning, a couple of weeks ago. So this whatever we are going to discuss will not be the latest trend in connection with the Gamma Knife Radiosurgery. So let me also go to the plan quality. Yeah, plan quality is the important area that we verify after every radiosurgery planning. So we use usually the conformity index or selectivity index. Selectivity describes how well a desired biological effect is achieved in a target volume without complications. So you can see here, if this is the prescription isodose volume, and if the prescription isodose volume, this is the prescription isodose volume, and this is the target volume, if it is covering 100%, the conformity index is equal to 1. Here you can see that is the perfect plan. But this is there is a partial overlap. We could see maker from here, and here the PIV is outside the target volume. So these are the different situations we address in a clinical setup when it comes to the clinical cases. So there are different conformity indexes or gradient indexes which are used in different institutions based on convenience and their experiences. Here we could see that there is high conformity and low selectivity. Here this is a plan of one patient where we could see that there is a high conformity because this tumor is covered perfectly, but we could see that the areas which are away from the tumor is also covering, so the selectivity is poor. But here in this plan we could notice that there is high conformity and high selectivity. These quality indexes are very much useful in the clinical setups to compare the plans and to finalize which plan is most suitable for the patient. So this is about the accuracy. So talking about the accuracy of radiosurgical treatment, it is not just the treatment accuracy, it also the localization and the motion accuracy. So there are 192 cobalt coplanar beams, there are multiple isocenters, there is sharp penumbra, there are multiple collimator combinations possible with a radiological accuracy of 0.515 mm. So the next question we have is, what is the imaging accuracy? What is the motion management accuracy? So when I started my career as a gamma knife physicist, this was one of my major concerns. So I started looking into the literatures, and I was looking for various options to find out this information, especially the stereotactic MR imaging, stereotactic CT imaging, angiographic imaging, CT-MR image fusion, and many other clinical issues that a physicist may encounter in setting up a radiosurgery program. I came across a number of publications from different authors. So it made me to start my research in that way. And I started developing many a few QA equipments and tools for doing the quality assurance and to ensure optimized stereotactic radiosurgery treatments. So these are all some of the devices I use for ensuring the stereotactic accuracy of the imaging systems, as well as to calibrate the angiographic systems, and also to estimate the accuracy in case of a SPECT CT, how to incorporate a SPECT CT images to the radiosurgical planning, as well as to verify the doses the patient received. So these are all some of the end-to-end testing devices I have performed in two of the workplaces I work with the Gamma Knife 4C and with the Gamma Knife Perfection units. So these are all some of the images that I acquired using different angiographic imaging equipments, SPECT CT imaging systems, and these are all some of the phantoms I use for the end-to-end dose verification of the Gamma Knife planning systems versus to the delivery systems. And this phantom I use for assuring the quality of the MR, the QA of the MR linearity and geometrical accuracy. So this is one of the publications and some of my experiences we published in the Gulf Journal of Oncology in 2013. So this we came to know some of the MR units got lot of error, which is more than 1 mm in many situations. Again, it depends on the sequences, depends on the many frequencies, many parameters that you use for setting the sequences. So in some of the situations, we had to use some CTMR image fusions or co-registrations to perform high definition radiosurgery treatments like microradiosurgery. That is very important for a physicist who set up the program. So Gamma Knife Icon has resolved some of the problems which is faced by many of the physicists. So that is what I understood with the stereotactic quantum CT. So where the image volume is automatically defined in the stereotactic space in Icon. So the mechanical coupling between the imaging isocenter and the lexual coordinate system is very much possible. So that could rule out many of the uncertainties which may happen with the MR imaging systems. And it is calibrated to the system, so it could assure better accuracy compared to the external imaging system. That is the way the science is developing. So it also has got some more the studies about the intrafraction movements using the thermoplastic mask and other ways. So we also need to understand when we consider the Gamma Knife radiosurgery systems, the normal brain dose when we are targeting. This is one of the studies from Li Junma and his team from the University of Francisco, and they showed the Gamma Knife dose, which is the volume of the normal tissue, which is receiving 12 gray, is lower 2 to 4 times better compared to the many of the other radiosurgical devices which are available in the market as CyberKnife, TrueBeam, or Novalis. So if you compare the volume of the normal tissue receiving 4 gray, where the limiting factor is 2.9 gray for the hippocampus cognitive decline reported dose, here also the radiation dose which is received to the normal structures are much lower compared to the TrueBeam, CyberKnife, or Novalis systems. So this is another advantage which is reported by the same author about regarding the extracranial dose. Here we could see that the dose which is received to the CyberKnife or LINAC is much higher compared to the Gamma Knife radiosurgery systems. So that is what they compared and they published in the same paper. So fundamentally, different technology produces fundamentally different products and different results. Here in Gamma Knife, there are 192 coplanar simultaneous beams and shifting of an isocenter with each shot. So each shot is an isocenter, and it is possible to modulate individual beams for flexible shaping of the dose shots. So there is a sharp penumbra which is due to the circular collimators and lower energy with almost 0.3 millimeter accuracy. So what are the accuracy influences in the current practice of Gamma Knife? Image fusion or co-registration or the testing algorithm, or image registration when it is registration, the image registration algorithms, or the dose calculation algorithms, or the image sequence or voxel selection. So this is based on the clinical experiences, we can say. So stereotactic corrections used in image acquisitions also very important, especially for the functional radiosurgery. So we could see that it has its own advantages as the localization error in CT and MR are minimized with the new approach. Motion management is a new option, more planning options, inverse planning is available, convolution-based approach is possible, more reachability, online adaptive, more confidence to the medical physicist. At the same time, it has its own challenges. Less gamma emitters with a thermoplastic mask. Motion management accuracy need to be evaluated because there are different settings for each motion, HD motion, and different settings for the modes to be selected. Image co-registration need to be evaluated. Image fusion accuracy need to be evaluated. Delineation error need to be addressed. Image quality assurances we cannot rule out because there are other issues like the spatial accuracy, contrast resolution. These are all we cannot rule out with this. So the radiation sources still we are using the radionuclide sources. And what about the energy transfer in the shots based on the dose rate which are estimated by the planning system? And there are uncertainties with the dose rate, sector dose rates. So these are all the challenges we have. So looking into the clinical applications, this is the data I received from the Lake Shell Gamma Knife Society for the treatment indications from 1968 to 2018 worldwide. We could see here, majority of the treatment indications were for malignant tumors, followed by benign tumors, vascular tumors, functional tumors, and ocular disorders. If you look into the benign tumors, we could see there is a number of tumors which are treated for various indications. And we could see that functional disorders again, we could see that the majority of the treatments for the functional disorders are for trigeminal neuralgia. And there are many other functional disorders, including epilepsy is coming up. There are many centers now coming up with functional radiosurgery. They are known as functional microradiosurgery procedures. So these are all the commonly treated or the clinical indications which are treated using gamma knife technology for the year 1968 to 2018. You could see that there are functional disorders from trigeminal neuralgia, epilepsy, Parkinson's disease, and many more. And there are ocular disorders. There are benign tumors. We can see that meningiomas, schwannomas, and many indications we could see that. So malignant tumors, again, and vascular tumors, and there are even, we could see that there are cavernous malformations also, good way it is coming up, because previously this technology was used only for the AVMs. Now there are other vascular malformations like cavernous malformations, other vascular disorders, dural arteriovenous fistulas, even aneurysms are treated by some of the centers. So these are all some of my experience that I have. So this is the patient which was treated in one of the center that I worked earlier. So this patient has got 36 lesions in the brain, which is impossible for any other radiosurgical device to treat. But gamma knife could treat such lesions with high conformity and selectivity, even comparing the even by delivering multiple doses to different targets. So that is the beauty of this technology. And there are many studies which exist, because there are some schools which exist the SRS to be followed after WBRT. It is not. The new school and the approaches, even from the ASTRO guidelines, says the maximum number of the tumors which can be treated using this technology is unknown, and it also talks about whether it is upfront WBRT is necessary or not. So that is a clinical question to be addressed by the clinical community who are practicing this. Another common indication is acoustic neuronoma. Usually it is treated by a dose of 11 to 13 gray, and in clinical studies shows 93 to 100% tumor control in most of the cases, with good hearing preservation for, the cochlea dose could be very well controlled, even for the toughest, the very close proximity tumors in case of acoustic neuronoma. And there are meningiomas, even large meningiomas, which could be treated. This is one of the cases I have experienced in my career, because there is a very large meningioma tumor with a 51.38 cc. That's a very large patient. The patient doesn't want to undergo surgery, so the neurosurgeon wanted to treat it. So we divided that old radiation dose into 3 fractions, and the patient underwent gamma knife radiosurgery by delivering 24 gray in 3 fractions. So the patient recovered after 6 months, 12 months. You could see that there had been many more improvements in the patients. Otherwise, the patient would not have been improved in such cases. So there are many more indications, and the meningiomas I have experienced. We have experienced, or there are many other centers in the world, great gamma knife centers. They are practicing this technology. So there is good tumor control for meningioma, even reported from Pittsburgh and European multi-center studies. So there is increasing evidence in the wealth of knowledge for all these kind of treatment indications. This is also a craniopharyngioma case, and is follow-up after 26 months. So there are brainstem gliomas. This is, you can see that this is the patient in the brainstem with the glioma. We treated using fractionated SRS, and you could see that the follow-up after 3 months. So there are arteriovenous malformations. They are vessel malformations, which are used for treating the vessel malformations by giving a large dose compared to the benign tumors, from 16 to 25 gray dose in a single setup. In some cases, it will be also done as a staged radiosurgery, and where the prognosis is very good, and 90% of the obliteration could be seen in the patients in the 2nd or 3rd year. So these are also one of the common indications for gamma knife. So pituitary adenoma is another indication for the non-functioning or the functioning. This one for the non-functioning pituitary adenoma, the results is better results. And trigeminal neuralgia is another challenging case for many of the centers, because in trigeminal neuralgia, we need to give a larger dose, 70 to 80 gray in a single fraction. So usually these plans are based on MRI. So when we try to shoot trigeminal neuralgia giving a larger dose, it is also important for the physicist to have the proper sequence of the MR imaging with the proper voxel size, pixel size, and with the non-accuracies to exactly deliver the radiation without deviating the targets, because this is very close to the brainstem. This is the root entry zone. So to deliver this higher radiation dose to the root entry zone is very challenging, but this is the challenge the gamma knife physicists need to do by designing protocols and sequences to generate, to deliver the treatment from localization till the completion of the delivery. And there are many other indications, and like epilepsy and many more. So in conclusion, I would like to conclude this way. The accuracy and the dose delivery quality are good compared to other available platforms. There is no doubt with the gamma knife radiosurgery systems. And the stereotactic imaging and the motion correction protocols need to be commissioned with care, with the proper equipment by an experienced medical physicist. That is very important. So the new IAEA protocol reduced many of the uncertainties for the transition, because in the previously from 18 mm to 16 mm, as well as different chambers, different positions, transition to the reference field were reduced by the new IAEA protocol. However, a multidisciplinary approach, a team approach, is very critical in the success of radiosurgery treatment. Thank you for your attention.
Thank you, Dr. Sajeev. It was a very good presentation, starting from the basic design of gamma knife to indicate clinical applications. Thank you very much for doing it. Colleagues who are attending, do you have any question? Please type in, and Dr. Sajeev would be happy to answer them. Dr. Sajeev,
So
are you
there
getting
are,
questions?
yes, sir, there are many questions, and maybe we will try to, I will try to answer some of the questions. And what is the criteria for patient-specific QA? Okay, that is a question I received. There is, in the concept of gamma knife radiosurgery, there is no patient-specific QA concept because this is a very rigid system where the accuracy and the configurations are compared in such a way that our gamma values will be less than 1%, 1 mm for 1%. So the protocol is set it in that way for the gamma knife procedure. So usually there will be no patient specific QA. But in some of the cases, yes, I have done it for ensuring more safety, because when we try to do some of the cases like uh, some cases like what I say OCD. OCD is obsessive compulsive disorder. So we have performed some singulotomy because it is again by giving a very large dose. So those kind of cases or some of the functional cases, we do something like that. Apart from that, the specific QA, what we do is there are some fiducial measurements which are possible in the imaging systems as well as the patient planning systems that need to be properly checked, and it should be recorded by the physicist or the treatment planning team. Because if we don't do that, we won't be able to get the accuracy that we are looking for. So that is the patient specific QA. We can say that's a patient specific QA for the gamma knife radiosurgery procedure. And there are specialized QA for the special procedures like obsessive compulsive disorders, or like if you wanted to treat trigeminal neuralgia, because in cases like trigeminal neuralgia, we cannot use the what I say the MP, or either what I say some of the APR images, the different, what I say, some of the T1 or T2 sequences we won't be able to use. So we need to define or design specialized imaging protocols without compromising the quality and accuracy. So that is what we do. So what is the recommended conformity index for tolerances? Again, ideally speaking, it is, that there is no tolerances that we have defined. It is from center to center, and there are different conformity indexes which give you values in different way. But in most of the cases, we try to make the variations within 1 to 2%, not more than that. So how does gamma knife spare normal organ better than cyber knife? Okay, so what I understood from cyber knife, because in the cyber knife has got a robotic arm, and in the cyber knife robotic arm has got a limited shielding compared to the shielding of gamma knife system, and where the sources are distributed in a special geometry in a gamma knife system. But where the cyber knife has got a high energy source, and also it has got a robotic arm which has a limit, which need to have a limit to control the weight of that arm to ensure the positioning of the device. So that may be the reason why there is a difference in the scattering from the cyber knife, and the scattering or leakage from the gamma knife is much different. So that may be the reason when cyber knife is used. And another reason maybe in cyber knife, there are some concepts by name nodes. So when you design a treatment, they are using some nodes. They are specifically defined points. So those points will be positioned for the exposures by the cyber knife system, which is using a single source. In this case, gamma knife has got multiple sources and multiple non-coplanar beam geometries are possible. Even one shot in gamma knife has got 192 multiplied by 5 beam combinations. So it's going to give the results of multiple arcs in a single shot, I mean a single isocenter. So that makes a huge difference between gamma knife and saber knife in case of intracranial lesions. And selectivity, how much selectivity? Definitely you can achieve a selectivity above 95%. In most of the centers are practicing 98 plus. So what is the prescription? Another question I have is, what is the prescription isodose used in gamma knife? Gamma knife, the prescription isodose used is from 40 to 60 isodose line, which is different from other systems. Because in the previous practices, the gamma knife units were using and all the prescriptions to 50% isodose line. But the current gamma knife practices, especially with the perfection, we are using 40 to 60% because that is giving a better dose fall. Is there any volume limit treatment and why? Yeah, now the volume limit issues being resolved by gamma knife by providing a fractionated radiosurgery option. That is what I tried to explain through the extend or the CBCT program. There are centers who are even performing 10 fractions, 15 fractions treatment using this technique. Even I came to some of the recent reports from some of the centers. But I have not mentioned this is not a common practice now, but that can be a common practice now, because nowadays with the new system there is no need to have a radiation frame. It can be that helps many radiation oncologists to use this technology without a neurosurgeon, because it has been the tool of neurosurgeons for fixing a frame, but now for the treatment it can use without a frame. So that's why the radiation oncologists also started using this tool. So another question, what are the beam data requirements for the TPS commissioning and what is the device used to acquire those? Beam data commissioning, what we use is the films. Mostly we use the films, EBT2 or EBT3 films, and some of the tools that we need for the gamma knife side that we need to bring from, that will be supplied by Electra. And there are some phantoms, of course, we need to have to acquire the stereotactic accuracy of the imaging systems, especially MR, CT, and angiographic devices. There are vendors who are providing such systems, but I am not mentioning the names here. But even in my experience, I have designed my own tools to perform those tasks. How you ensure accuracy of patient setup? So the accuracy of the patient setup is now can be assured using the stereotactic cone-beam CT. The stereotactic cone-beam CT measurement would be able to give us the verification. In addition to that, the new HD-based motion control system also gives us information about the accuracy. And another question is, how do you measure global minimum dose in metastasis? Global minimum dose, if you want